Hey there, pharmacy professionals. Let's talk about one of the most common things you see every single day at the counter, allergic rhinitis. In the next 5 minutes, we're going to sharpen your skills so you can go from assessing a patient to taking decisive action just like that. Let's jump in.
Okay, picture this. We've all been there. A patient walks up, they're sneezing, their nose is running, and your first job is to play detective. Is it a cold or is it allergies? Seriously, the answer to this one question sets the stage for everything that comes next. Getting this right is absolutely fundamental.
You know, a lot of the time, the clues are literally written all over your patient's face. We call it the allergic face. You're looking for those allergic shiners, those kind of dark circles under the eyes. Check for Morgan lines, those little extra creases below the eyelids. And, especially with kids, you'll see that transverse nasal crease from them constantly wiping their nose upwards. We all know it as the classic allergic salute.
So here's our game plan. We're going to walk through this just like a real patient consultation. We'll start with assessment, understand the reaction, set our goals, go through the treatment playbook, pick the right medication, and then we'll wrap up with special cases and follow-up.
Okay, first things first, assessing the patient. This is all about asking the smart questions so we can get past the obvious sneeze and figure out what's really going on. Your first big decision is knowing when you can handle it versus when you need to refer. You're looking for those classic allergy signs, right? A clear, runny nose, that itchy feeling in their nose and on the roof of their mouth, and of course, itchy, watery eyes. But, and this is a big but, if they mention red flags like symptoms only on one side, a fever, facial pain, or thick, colored discharge, that is your cue to refer them out, no questions asked.
All right, let's get into the why. Really understanding the science behind the allergic reaction is what makes your recommendation a targeted strategy instead of just a guess. So let's peek behind the curtain at what's causing all these symptoms.
So this whole thing happens in 3 phases, and it perfectly explains what your patient is feeling. Phase 1, sensitization, is totally silent. They don't feel a thing. But then phase 2 is that immediate histamine-fueled misery, the sneezing, the itching. And then hours later, phase 3 kicks in. That's the late reaction, the inflammation that causes that stubborn, lingering congestion that really messes with their day.
So, with that science in mind, we can set some really clear goals. What does a win actually look like for our patient? It's pretty simple, really. Our goals are threefold. First, stop the symptoms before they even start by avoiding triggers. Second, relieve the symptoms they're already having. And third, and this is crucial, do all of that with the fewest possible side effects. Every single recommendation we make has to check these 3 boxes.
Okay, so how do we do it? How do we hit those goals? Well, we use a complete tiered approach. And listen, medication is a huge part of the playbook, but it is not where we start. Think of your strategy as having 3 lines of defense. The first, and honestly the most important, is prevention, just avoiding the allergen. The second line is non-drug therapy, things like saline rinses and staying away from irritants. Only after that do we move to the third line, the medications, which we tailor specifically to the person standing right in front of us.
Here is a super high-impact counseling tip you can use today. For any patient you even suspect has a dust mite allergy, the single most effective thing they can do is this. Tell them to get zippered, allergen-proof casings for their mattress, their box spring, and all of their pillows. It's such a simple change, but it can provide massive relief.
And now we get to the meds. This is where your clinical judgment, guided by the evidence, and what you know about your patient really shines.
So before you even think about grabbing a product off the shelf, you have to classify the rhinitis. Is it intermittent, meaning symptoms are less frequent, or is it persistent, where they're dealing with symptoms most of the time? This one distinction is the key that unlocks the entire treatment algorithm.
And the algorithm itself is super straightforward. For mild, intermittent symptoms, a second-generation oral antihistamine is your go-to. Easy enough. For basically everything else, so moderate to severe intermittent and all persistent cases, the guidelines point directly to intranasal corticosteroids as the first-line therapy. It's that clear.
And here's why. This chart breaks it all down. Oral antihistamines, they're great for itching and sneezing, kind of hit or miss for congestion. Decongestants are really a one-trick pony. They only help with congestion. But look at intranasal corticosteroids. They are highly effective across the board for the runny nose, the congestion, and the sneezing. They treat the whole spectrum of nasal symptoms.
Now, for those patients with really bad congestion, they are almost always going to reach for a topical decongestant spray for that quick relief. And this right here is where you have to step in with a critical warning about overuse.
3 to 5 days. That is the absolute maximum they should use those sprays. Any longer, and they risk rhinitis medicamentosa. That's the rebound congestion that can be way, way worse than the original problem. This might be one of the most important counseling points you make all day.
Finally, let's quickly touch on tailoring care for special populations and talk about why closing that loop with a good follow-up is so important.
When you're treating kids, safety is everything. Remember, absolutely no decongestants for kids under 6. Always reach for a second-gen antihistamine over a first-gen to avoid that drowsiness. And if you're going for a nasal corticosteroid, budesonide and mometazone are preferred because they haven't been shown to suppress growth.
For your patients who are pregnant, intranasal corticosteroids are considered safe. Same goes for cetirizine and loratadine. The big thing to remember is to avoid oral decongestants in that first trimester. For moms who are breastfeeding, the advice is pretty similar. Intranasal corticosteroids and second-gen antihistamines are safe choices.
Look, your job isn't over when the patient walks away. You've got to have a follow-up plan. Tell them you'll check in after a week or so. A huge reason therapies fail is because of bad technique, especially with nasal sprays, so make sure you counsel them on that. And hey, if there's no improvement after 2 weeks of them doing everything right, it's time to rethink, maybe switch therapy or refer.
And that really brings us to our final thought. When that patient comes back in 2 weeks and tells you the first-line therapy didn't work, what's your next move? Your answer to that question is what underscores your vital role. You're not just handing out medication, you're actively managing their care, ready to reassess and adapt. That expertise is what makes all the difference.